Amine, thank you so much for the great introduction. And Rosine, thank you so much as well for the great work and for updating the public on the great work that you guys are doing on Twitter. You guys are doing a great job. I couldn't start without really appreciating you for the great work you're doing. Like Amine rightly said, my name is Jude Kong, and I'm the director of the Africa-Canada Artificial Intelligence and Data Innovation Consortium that is leading a team of 52 researchers across 9 countries in Africa that have been informing COVID-19 policies across these countries. Today, I will share some of the work that we did in line with this project, which is entitled The Impact of Social, Economic, Environmental Factors on the Dynamics of COVID-19. This work is generally sponsored by the Canadian International Development Research Center, IDRC, as well as the Swedish CIDA under the Global South AI for COVID-19 program. Before I move on, I really want to acknowledge the team of researchers leading the 52 researchers across Africa and here in Canada, as well as my great postdocs, grad students, and other grads that have done most of the work, working really hard, day in and day out, and other collaborators that I have like Ed and Sarah, and the post lab in Jakarta. These are the groups that the people that I talk to, they become my family. I talk to them almost every day. Constantly, not almost, but every day. They have done almost all the work here in addition to some of the policies that have been driving the dynamics of COVID or that have been put in Africa within this COVID period. This is a team behind that, especially in the 9 countries where we are currently working. So I really want to thank them. Especially my postdocs. Thank you so much. I think some of them are here listening. Some are not in this picture, but I really want to thank all of them, and grad students as well as undergrads. When COVID started, actually, and we were generously supported by IDRC and CIDA to start the work that we are doing in the 9 African countries where we are currently working. As all modelers would do, we wanted to understand the pattern in each local community. Now, here you will see the aggregated data for the whole country. But when we started this work, when we go to each country, given our connections in the local communities, we wanted to study from the local level, collecting data at the local level and recognizing the patterns. But one thing stood out, be it between local communities or between countries, that we noticed. And what we found was that initially, COVID was taking a different dynamics across different countries and across different communities. So we decided to focus on countries. Here, I've just put a few countries. On my left here is South Africa, one of the countries where we have been informing policy, COVID-19 policy. Hand up to Bruce for the great work he's doing down there. And then on my right here is Nigeria, one of the countries where we have equally been informing policies. Head off to Professor Oduola for the great work that the team is doing there. And then here is Australia, where most of our people listening to this talk are currently based. If you look at South Africa, Australia, and Nigeria, you realize that the initial dynamics is completely different. Look at how it went in South Africa, starting slowly and then move this way. And again, I must admit that this is without accounting for underreporting, but just looking at the reported data. If you look at here in Australia, look at the way it went up. And then if you look at here in Nigeria on this other side, Nigeria and South Africa are completely different. And so we started asking the question, what really happened that even between communities or between different countries, COVID-19 started and was following a different trajectory? Within us, just sitting us and deliberating, we hypothesized that, like all modelers, when you have your system, you have questions that are disturbing you. Well, before you come with a mathematical statement about those questions, you make a hypothesis about the system. So we hypothesized that demographic, social, and environmental factors were associated with the initial growth of COVID-19 across this country, that we had nothing else to allocate to this or to say, well, this is responsible for this. We could not just go on with this without ruling out the fact that of some of our colleagues arguing that why can't we think that the enacted policies in different countries may have affected this initial trajectory? But upon deliberation, actually, our explanation was that, well, if such an explanation is true, then this will contain statistical indigeneity. What we mean here is that the initial growth of COVID caused the response. And therefore, the response cannot simply be used as a predictor of the initial growth. So in so doing, we think that the policies put in place should not be responsible for the trajectory, for the dynamics, for different countries having different trajectories, because the trajectory in those countries led to the policies being put in place. So instead, we then focus on studying those pre-existing country characteristics, demographic, environmental, and social variables that we felt that they existed before COVID. And so these factors may be responsible or may be able to explain why different countries had different trajectories. And this is very important in the future going forward, look at other pandemics, so that we identify these factors that may be responsible for this initial trajectory or initial dynamics. So we move on to start outlining those factors that we felt that may be responsible. We thought of, well, demographic variables, and in the demographic variable, what could come to our mind first was population of ages 20 and 35. We equally thought about the total population of a country. We thought about the disease, which means that the mortality rate from lower respiratory infectious diseases in that particular country. We equally thought of mortality rate from infectious and parasitic diseases, where we thought that this may have played a role. Maybe people have learned from the past. Sustainability, there were a lot of theories out there. And so we searched everything, every news article, what the theories that people were giving out there, we try to verify them if that could play a role and add others. For economy, we look at the Gini index, which is the income inequality index. We equally look at the ease of doing business, where the ease of doing business here, by that I mean, how likely is the country open? This will account for the number of NGOs and will account for NGOs being able to organize themselves and inform policies when you have such a dynamic. If a country is open to business, if you take a country, for instance, like North Korea, and then you compare with a country like South Africa, well, it's easy to do business in South Africa. So the likelihood of people in South Africa being informed by the different NGOs is very high. So we accounted for that. And then we move on as well to look at environmental variables. We thought of temperature, precipitation, air pollution. And then we equally looked at social variables, the average population use of social media to organize offline action. How often do people use social media to organize protests and other things, or just action to come together offline? Then we talked about internet filtering, government internet filtering. And we equally talked about air transport. How often was the traffic? And I know this could be related to the ease of doing business, which we dealt with. For the response variable, we thought that because we are thinking of the initial trajectory, which is the initial dynamics, the initial rate by which COVID was spreading, one factor that will explain to this will be the basic reproduction number. By basic reproduction number here, I am referring to if you bring in one person in a country, how many persons will that person infect within the time course of his infection? Within the time course that a person have the virus in him, how many persons will he infect? And we decided to use this statistical model where we modeled the basic reproduction number using the spreading rate as well as the serial interval. T here is the serial interval, R is the spreading rate. By serial interval here, which was already reported in the literature, is a time lag between the symptom onset of the primary case and its secondary case. For instance, somebody is infected now and starts showing symptoms, the lag between when he starts showing symptoms to when the other person who will infect will show symptoms. And then that was already reported in the literature. So we didn't estimate this serial interval, but we focused on estimating the spreading rate. And in order to estimate the spreading rate, we look at the data initially at that point, everything was growing exponentially, but we know that, well, at that particular point, when people start adjusting their attitudes, policies start getting in, the virus will at one point run out of the number of people to infect. And when that happens, well, an exponential model could not work, it will start plateauing. And so we decided to use a logistic growth model where the spreading rate was captured by this intrinsic growth rate. And then the typical carrying capacity that you have in the logistic model, well, that could be thought of as the theoretical epidemic size without intervention. And with this, I want to stress the fact that we use the daily confirmed cases. By daily confirmed cases there, is because we couldn't use the cumulative data because we carry over the errors from the other day across. And so we decided to use the daily confirmed cases to fit a logistic growth model to the incidence data. Again, there were already reports that supported using the logistic model. Ma and his colleague did a work in 2014, a subsequent one in 2016, where they compared different Richards model and using exponential by Richards model, the exponential and the other models, and the logistic model was the best model. So that supported our argument of using the logistic model. When we fitted the model to the data, well, we did obtain good result, but the aim here was to estimate this growth rate here. I just lined those ones with the lowest growth rate, just adding Canada here, and those with the highest growth rate across here. But I want to stress the fact that a country with the highest growth rate does not speak to the end dynamics that there will be more persons infected in that particular point. No, because again, we are allocating this, the initial growth rate, the initial dynamics, to the pre-existing country characteristics. Now, when we did this, we realized that South Korea had the highest growth rate or R0 value after using a serial interval of 5 point something, which was what is found in the literature. We found out that Australia had an R0 value, was the second, and then Luxembourg followed that. Countries with the lowest R0, based on the number of countries, again, we didn't estimate this for other countries, but in the analysis, we left out some countries because we did not have data on some of the covariates for all the countries. And so we found out that Dominican Republic had the lowest, followed by Ghana, or was tied with Ghana, and then Indonesia. And for the mean, we obtained a mean value of R0 1.7 with a standard deviation of 0.57, with Belgium, Iceland, and Japan being closer to this mean value. And so this is a distribution. This other country here is, even though we had data to estimate this when we're comparing these, some of the countries did not have some of the covariates that we really wanted to verify. And so we left them out along the analysis, and that's why you may find it this way. Now, for the statistical analysis, the first thing that we did, now that we already have our covariates, we have our output variable, which is a basic reproduction number. The first thing that we did was to check for collinearity, obviously, to ensure that one covariate is not explaining what another covariate is already explaining. And we did that and eliminated some of the covariates because we considered many. I want to point out why we choose to use a generalized additive model, which is very common in ecology. Unlike public health, we barely use it. But the advantage of this over the traditional regression model was that it could capture the non-linearity in our data. We did not, from the onset, assume that the dynamics, the relationship is linear. So we assume non-linearities in the dynamics. And so we wanted to capture that. I just want to remind the public listening to this of what a generalized additive model is. So basically, you could think of this as your typical linear model, but then this is not a linear function, it's a generic function. G of U here is a monotone link function relating the dependent variable to the given covariate, and beta is any strictly parametric component in the model. You can think of this as just the intercept, and then f of x here is a variable explained by the non-parametric smoothing functions. And then these are independently distributed, normally distributed random variables. just, you could think of this as just the typical linear regression model, but then these are not constant parameters, these are nonlinear functions. We equally try to pay attention to the fact that, well, different countries may have different reporting rates and testing rates based across countries. And we started by accounting for this random effect. We consider region, assuming that the fact that you belong to a particular region will affect the way you collect your data, will affect the number of cases that you have. And so we took region as a random effect. If you were found in Asia or other places, maybe you heard from China and adjusted your attitude or something, being very close to that. So we assumed that region was a random effect. We took the total number of days from when China had their first case to the number 30th case as a random effect as well. And then we equally use gross domestic products as a random effect, as well as the average underreporting rate of the country. So we accounted for the underreporting in our analysis. So we use all of that as random effects and not fixed effects. When we fit this to the model, we did obtain very reasonable results that we felt that we could start looking at the association. Again, I just want to stress the fact that we are not looking at causation, we're just stating here association. And we found out that our model was able to explain 75.3%. Well, to us, this indicated very high explanatory power and predictability. I'm not going to use p-value as a basis for people to always judge whether models fit, but relative to what we did here, we picked those with the lowest p-value. Again, it's arguable whether p-value should be used as to judge whether models, whether a parameter is significant or covariate is significant or not. But we use, looking at these p-values here, the number of younger persons in the age between ages 20 and 35, the Gini inequality, the income inequality, the number of city dwellers, the number of people living in the urban city, and the use of social media to organize offline action. These four stood out as being very significant. So for the purpose of time, I will focus on explaining the way we decided to interpret these four covariates that stood out as driving the initial spreading rate of COVID-19 across countries. Again, may I remind everyone that initially when we were looking at it, what we were looking at was, why is it that if I'm in South Africa, the data is taking a different trajectory from Australia? What can explain that? And we hypothesized that pre-existing country characteristics. And among those pre-existing country characteristics, we pick all these demographic, social, environmental variables to account for that. And so when we did the analysis using a generalized additive model, these four stood out. Again, we use p-value as a judgment for this, but this could be argued that, well, this is relative, but that's what we use. So let's look at the positive relationship between the R0 value and the use of social media to organize offline action. We concluded at this point that this was very earlier on, that this trend may be caused by the propagation of false information on social media. There were a lot of false information spreading at that particular moment. Last night I was talking to, I was just texting with one of my colleague, James Obinski, and he texted me, if Fox News existed within polio, everyone would have died. Well, I'm not saying Fox News is responsible, I'm not blaming Fox News, but I just thought about that story last night, and I thought about not just that, because when this news, I don't want to say far-right news, but when some of these news channels tweet about some of these conspiracy theories, a lot of people follow them blindly. So it leads to a point where, and again, I'm not criticizing Fox News here. I'm not saying that Fox News have led to that, but I'm just saying that I'm just laughing at the situation that happened last night. And then I'm looking at this and remembering what we were testing last night about how you have this far-right media, again, you still have equally far left, I'm not blaming the right, that may have been spreading false information at the onset for reasons that I cannot explain. I would tell them they were false information. Again, they can argue. I need to give them a chance to justify whether they were false or not. But from my own perception, permit me to conclude that they were false information. And this alone may have caused that spread. I have not concluded that. It's from my own perception. There's nothing showing that the information was false. I'm not criticizing any media house, but from my own perception, I assume that it's false based on my personal interest or from where I'm looking at it. But when we did this, we strongly believe that social media was going to play a big role, even though at the onset it actually played this negative role. I see social media is partly playing positive role as well as still affecting the spread. But the hope is that social media was not for to push very, very dictators around the world to say, oh, no, we need not to ban social media to jump on that. No, we are not trying to say here that social media is something to prohibit. We're saying that, well, because some of the information that's spread around there may have caused people to go around doing things or not believing that this is real. There were a lot of things about these being manufactured, just trying to control people. There's not a lot that I got from the various social media groups that I was reading, and people thinking of things that could cure it. And I remember reading at some point somebody saying about one particular alcohol being able to drink and it cleans everything. Another person talking about a particular tea that you could drink. But when people do that, they become super spreaders because they feel so powerful that they can just go out there now and do anything. Again, I'm not judging them. I'm not saying whether they're wrong or right, but I feel that they end up being super spreaders because that has not been proven to work. And so we believe that when they spread that in the social media, it helps actually cause people to go out there and interact, thereby spreading the virus. We equally looked at the number of youths between the ages of 20 and 35. And our initial thinking was, well, when you look at if a country has a large youth population, this youth population may confer resilience against the disease while at the same time increasing the transmission rate, because a lot of young people were just partying around, right? The partying, either hiding in their basement and partying around campuses. You had a lot of parties on campuses for the universities that were still open at that time. And so even though they confer resilience against the disease, the tendency is that they ended up transmitting it. But meanwhile, a country with a lot of the old population will be more susceptible, but exhibit a reduced transmission rate, the activities. And so the synergistic result is that an intermediate level, and that's why we have this concave result. So this intermediate level will lead to a highest R0 value. That was how we interpreted this. Again, when we look at the Gini inequality, which here is referring to income inequality across a population, it may mean that a country with a high, when we have this concave behavior here, what we're thinking is that a country with a high Gini inequality, all these are scale values though, when you see negative here because they are scale, we scale the values. A country with a high Gini inequality may lead to may mean that you have physical segregation among the population, and thus that physical segregation may have initially halted COVID growth across the population. We're not saying that that's physical segregation was good. That could be an explanation. Again, this is not confirmed. This is just us saying that this may have caused that, led to that. The low Gini inequality here may indicate better social integrations, and those fewer people are left behind or at a high risk of exposure. That was our interpretation of as to why you have this concave behavior, where if you have a lower Gini here, then you have a low covariate, and you have a high Gini, you have a low spread rate. Again, I'm interpreting the spread rate in terms of the basic reproduction number. So thinking at this point just was, well, if you have a low Gini, it means that there's a better social interactions, and thus fewer people are left behind or at high risk of exposure. If you have a high Gini, there is more segregation at the onset. People are segregated, and those may reduce the spread. Again, this is not confirmed anyway. This was just our interpretation, thinking our way. And when we looked at the number of city dwellers, number of people living in the city of above 1 million, well, it was clear to us as to why a high population in the city will lead to a high spreading rate just because of high contact, people touching each other. But it wasn't clear to us as to this convex relationship where a lower population is almost leading to a high R0 value. So we could not conclude on that. A lot of theories could be hypothesized on that, but that's not everywhere. If that was just on Africa, we could hypothesize as to having in the city, mostly having younger people and so on and so forth, but that was around the world, and so it was difficult for us to come up with a reasonable explanation. When we decided to plot the country's profile just on this cobweb here and against the covariate and R0, by just picking only the 4 ones that showed to be very significant. Again, I want to use the word significant in quote here because that is relative. I don't want to always claim that p-values should be used to judge significant level, but that's relative to who is judging. But I just want to use this for significant and to say that what we actually find out was that the country profile using the 4 most significant value actually matches the R0 value that we got. If you look at it, these are countries from low R0 value to high R0 value, per se, some of them that we picked. And when you look at a country like Ghana, you realize that it has a high Gini inequality, well, low use of social media, and this is confirmed with the R0 value, and a low number of people living in the city per se, and a high younger population. If you look at a country like Canada, you have kind of a low youth population per se, compared to that, a low Gini inequality, a high use of social media, but not as compared to US, and then kind of a high number of people living in the city comparatively. And so this matches exactly the profile that we have for our R0 value. By so doing, what we found out from this result was that, again, I want to stress the importance of that our analysis is based at a country level. And so this analysis, even though when we went to the various countries that were working in Africa, we look at local data and compare across communities. But in this result here, we only compare between countries without explicitly correcting for R0 estimates, using temporal trends in testing, reporting, and mortality. So then an international perspective like ours, what we thought was that can help understand COVID-19 in a broader context, even though we sacrifice the ability to infer local causality or realities. So we lose track of the local realities, but this can paint a very global picture so that we prepare for the future. I want to emphasize here that R0 is not an indicative of eventual outbreak size or the nature of subsequent waves. Again, Australia having high R0 doesn't necessarily mean, if you look at earlier on, Australia was able to control it before later on things change, but it doesn't necessarily mean an eventual outbreak size will be higher. It's just that initial dynamics, and we are attributing that initial dynamics to pre-existing country characteristics. So the factors influencing R0 identified here reflect the naive or intrinsic factors that may determine the country's vulnerability to the novel coronavirus. These are the ones that, assuming everybody is naive, and this will happen a lot in future pandemics. What are the factors that we need to start paying attention on? Gini inequality or other factors? Again, I'm not blaming that, but this just push a conversation so that we look deep into them. I'm not letting that into causality. I'm saying there's an association. Let's start looking at that association. It doesn't mean it's causing that. The other values calculated here, these are just, again, like I already said, these are just baseline value as to how, earlier on at that point, how COVID-19 will have continued spreading if interventions were not put in place. But we all know that, or if interventions were prematurely lifted at that point. And this is, we did another study where we looked at that when intervention were put in place and the spreading rate went down and they were prematurely lifted, we compare that. So if it's prematurely lifted and nobody has immunity, we assume that it will continue growing at that same rate if people have not started changing their attitude. So this study from that time going forward and even at this point, it will actually help a lot in controlling the pandemic going forward and in actually helping with future waves. We are here to live with COVID-19. There will be future outbreaks. So a study like this will help a lot to inform policies going forward as to which factors, pre-existing country factors, need to be addressed such that we should not have, well, the country should not be impacted because of other factors, but rather, if we are able to put in policies, we will account for all those factors and see how we can help control them to ensure that we get the best out of the policies that we're putting in place. I really want to thank all of you, and this work here was published in this PLOS ONE journal. I really want to thank all of you for listening. Thank you, Rosanne, and thank you, Eminette, for inviting me to share my work with you and for the great work that you're doing. We really appreciate it. Thanks a lot.
Yeah. Thank you, Jude. Is there any question from the audience? I can see that Sultan had put a question. Sultan, would you like to say something? Hello, is Sultan here?
Yes, I was just wondering about the logistic model. So that's like the solution of the logistic equation is a function that is increasing exponentially and then it stays constant when it reaches carrying capacity. And so why would that be a good model for an epidemic dynamics? Since this is for a population dynamics, which can reach some steady state, some equilibrium, but an epidemics usually is not reaching a steady state at some high number of infection value. So yeah, that's a question.
Thank you. I just want to draw this and show you something. When you have an epidemic, most of the time it grows exponentially. What tends to happen while exponential models do not work, or when we try to use just a geometric series to interpolate this, is that at some point the virus will run out of people because people change their attitude and the virus will start coming down. In studies like ours, we didn't pay attention to what will happen when it start coming down here. Now, if you use an exponential growth model, well, it will keep on going up, right? But people change their attitude and the virus start coming down. In our case, we bother much about what happened to the peak here, because we know that at this point, there are policies already put in place that start bringing this down. This is why a logistic model and other Richard model will be able to estimate why we need it. We are not capturing what happened when the virus started losing track of the number of people infected. Rather, we're paying attention to the dynamics in the initial dynamics here, when people have not started controlling their behaviors. And so that's why a logistic model will capture this. Again, why a logistic model and not a straight exponential model? Ma and all have done a study by comparing the different Richards model in 2014, and a logistic model better performed this. Well, eventually they always plateau, and so that will be able to capture this. I don't know if I answered your question.
Yes, thank you.
Yeah, so can I ask following that question? So all the analysis here has been done for like the beginning of COVID-19 pandemic, right? Like, exactly. Yeah, okay. So you haven't looked at like another peak, like the exponential peak of another wave?
We did compare in a separate study. We accounted for immunity and compared the second wave and compared the properties that were still in place. So when countries lifted the policies that they put in place and it led to the second wave, we compared that to find out which policies, how people control their attitude going forward. So that's a different study that we looked into that just to study, well, naturally, when countries lifted the restriction that they put in place and they started going up, by how much did people control their attitude, accounting for these pre-existing country characteristics? Yes, that's the study.
Okay, thank you. Is there any more questions from the audience? I think Yanni.
Yeah, I'd like to follow up. So thanks for the very nice talk. So following up from Amina's question, when you do the study at the start, the biological status of the population is kind of fixed. It hasn't been affected by infections and ensuing immunity or vaccination. And if you were to look at multiple waves that follow, do you have some thoughts of what would be the best variables to capture that biological state of the population cohort, just like you did for the economic state via the Gini index, which is kind of constant, but the biological state is not? As a covariate, right? So if you would look at different waves, say in South Africa, you know, the biological state at the start of every wave is different. If you or your group thought about that?
So if I got your question correctly, yes, at the start of every wave, the biological state will be different. The epidemiological state, why? Because part of the population already have a certain level of immunity. This could be conferred by, or people are already changing their behavior independently. Best, for instance, right now, the way people act is completely different from when COVID started. Is that what you are? Is that what you're asking or looking at? Because when COVID started, everybody was naive, so COVID could be able to touch everyone. But later on, in subsequent wave, there is some level of immunity already existing. Is that what you mean here?
Yeah, indeed. I mean, the combination of immunity, human-made immunity, i.e., vaccinations, and variants, right? You know, alpha, delta, etc. So these should play a role, I think.
Yes, obviously. Basically, if you were to look at the growth rate at that point right now, where you take this R0, you need to account for the number of people that are susceptible, right? That would be the spreading rate. If you look at the spreading rate at that particular point, that will play a very big role. At that particular time now, the factors that will be influencing these growth rates will no longer only be based on pre-existing country characteristics, but rather on the way people are changing their attitude, on the policies that are put in place. So those need to be in place, in addition to some of these pre-existing country characteristics if they have not been addressed. So those will still be there, but then the rate of growth will be lower compared to the initial growth. Why? Like you rightly mentioned, people have changed, the biological status have changed, people have changed their attitude, vaccines are in place and other things. So everything will change there.
Yes, thanks. And are you aware of some data set that aggregates all of these kind of episodes or you know, the combination of the work that you did and as well aggregate vaccination, infection levels, etc.?
Thank you so much. We do have another work that we did with that, a lot of different data sets for the second wave. I mentioned that growth rate, but not with vaccination. So I'm not aware of work that took into account vaccination, but I'm aware of work that have accounted for people changing their behavior as well as the immune level from previous infection during the first wave, but not accounting for vaccines.
Great. Well, we might talk more offline. I mean, this is something that in AI4Pan we've been considering, but we haven't taken as much action as you have in this work. So thanks.
Thank you.
Thank you so much. We should definitely talk online.
Thanks.
Thank you.
Yes, any more questions? Michael has put a question. Would you like to voice it out?
Yes, thanks. Happy to. So basically just to address the problem of underreporting, which of course, as we know, say in the China case, might have been 5 or 10-fold underreporting in the initial confirmed cases. And so given that that's a problem, I just wonder whether it would be possible to, or whether you've considered doing the analysis with, if you like, a corrected figure on daily confirmed cases, corrected by what we know about the pandemic since, and then seeing if the same things hold, whether basically how sensitive is the analysis to potential underreporting.
Thank you so much, Michael. And that's a very, very good question. I really like that. When we started this analysis, the London School had actually estimated percentage of underreporting across countries. And so we used that data from the London School, which was based on the percentages of underreporting. We use underreporting as a random variable. The underreporting percentage. If you look at the number of covariates that we put here, the fixed effect covariate, we had the average underreporting percentage. And this was taken from the work that was done at the London School of Additive. My postdoc currently right now Ching had actually estimated the underreporting across countries, but we're not taking that into account. But yeah, this will be something to look into. So we just, on our part, just recently estimated all the underreporting across all the countries, but when we are doing this work, we only use the work from the London School of Hygiene, where they did the percentage underreporting.
Yep, there's another question from Yanis on the chat. Have you considered including data from sewage levels of fire?
This is a very good point from your question, Yanis, and thank you so much for your textbook, Yanis. You guys gave me a Bible, statistical machine learning. When it comes to sewage data, currently right now, we using it on these, we have not considered using it on these. What we consider using that for was whether that could be used to detect, whether we could draw a correlation between the case spike in the hospital and sewage data to be able to detect if a new variant exists in the city. But currently right now in Toronto, we have come to the conclusion that because people are no longer reporting their cases, the only way we could have an estimate of case count will be to rely on sewage data. So I think any other analysis that we'll do going forward will be based on that. But before now, I had not considered doing that. But you brought a very good point, and it's a conversation where we are already having that conversation among ourselves to say, well, people are no longer reporting. Where can we get an accurate estimate of the number of cases if we have to continue our analysis?
Thank you. If I can ask a corollary to that, what if you had a magic wand and you could decide how data should be collected? What would your wishes be? Like, what would you love to know as a statistician? And I mean, one obvious thing that I see is that, for example, the variant is not recorded for every case. Okay, it's only, at least here in New York City, it's only a fraction of the cases that the Department of Health goes and monitors further to figure out what variant that positive case is corresponding to. Would that be something that you would love to know as a statistician? Or what else?
So if I got your question correctly, just to repeat the question so that I got it correctly. So basically going forward at this particular moment where we find ourselves, what I want to know from the data as a statistician going forward, we talk about the variant, the number of cases reported, correct? But if people are no longer reporting, there's so much underreporting, it's difficult to get an accurate count, right? You're aware of that? Or when you talk about the variant here, it will be the variant of the true case count and the underreported count, or what variant are you looking at here? Variants are you talking about here?
Yes, like think that if you could go back in time in, let's say, March of 2020, how would you advise the CDC, the different health departments, on how to collect their statistical data on the pandemic? What variables would you ask them? Please collect this. Please monitor this. That's what I'm trying to get at.
Oh, thank you so much. Okay. Again, it may be very biased based on the type of analysis that I am mostly interested in. But when they're collecting data, the case fatality ratio is very important to me. I find that this is really very important. One parameter that I am interested in, the case fatality ratio is very interesting to me. apart from the case fatality ratio, then I want to know about the number of the pre-existing conditions. Not all countries were collecting this to know exactly when people came in, for those who died, did they have any other existing situation? Now, when it comes to a place like Africa, because I spent a lot of time doing a lot of work there, what I want to know from there actually is when you do not report on younger people dying, how many of those cases distinguish really clear distinction between the malaria cases and the COVID cases in their own case, given that that was an issue. So if they could come, somebody comes for COVID, they do take the two tests to generalize whether it's malaria or COVID. That would be something that would be very interesting. So that if the person died in the hospital, it's very clear how many young people actually die of COVID in Africa, because it's really not clear at this point whether they die of malaria or COVID. So those are some of the things that I will do. But here in Toronto, I will mainly focus on the case fatality, the number of people that came in and died, the number of people that had pre-existing situation before they came into the hospital. And even now with vaccine, which is something they are not doing, I will be interested to ensure that, well, from those who come into the hospital a second time, those who were already infected before, those who have the vaccines, if that data can be collected, that would be very helpful. To be able, why is that helpful to me? I'm looking at endemicity. In order to be able to judge whether we have reached a point where you can define your own endemicity, that data will be very helpful to me. But then going back then, when we just started, I would have just focused mainly on the pre-existing condition, the case fatality ratio, and just to know basically out of those admitted, how many people die, and the number of cases that they were already collecting, and trying to ensure that they did a diligent job. And I think in Canada, we did a great job in collecting that data.
So can I ask, like, I've been looking at these like waves episodes, so with your work, I think it's very relevant. So do you think like something like previous characteristics of the like previous wave could predict the next wave or something like that? Like with the sort of work that you have done, I think that's really amazing. Yeah.
Thank you, Aminit.
Yeah.
So my initial answer will be yes. Why? If countries did not control their behavior, assuming that nobody was had immunity, then the dynamics will continue the same. Now, if we account for the level of immunity, account for the way people have adjusted their behavior, then we can be able to say, well, if they are if we quantify that threshold value by which they have adjusted their behavior, that will lead to the control coming to a point where we can move on with life and just have normal spread within the community without overwhelming a hospital system. Then if in the future, people start changing their behavior and you realize that they have gone beyond that quantity, then that may trigger another outbreak, assuming that the level of immunity in the country is within the threshold that you had earlier on established, because people may lose their immunity in the long run. And so, yes, this work could be used to predict future pandemics, but we need to account for the level of immunity in the country and the way people are controlling their behavior, the policies put in place, or people just naturally controlling their behavior, which I can loom all of that into immunity if the virus cannot find them. So if that is accounted for in the future, we can be able to say if this threshold, if the value goes above this threshold, this may lead to trigger another outbreak.
Yeah. Thank you. It will be good to chat later on with this. Yeah, is there any more questions? One more question from the audience we can take for the time limit. Okay, I don't think there is any more. So thank you so much, Jude, for joining. It's a great talk, and then we are very happy to have you here. And on behalf of everyone, I'd like to thank for your time and your talk. Thank you so much.
Thank you very much.
Sorry, there is that. Can Jude put in the chat his preferred way to be contacted? Someone
Thank you.
Yeah.
Thank you very much.
Thank you so much. Okay.
Thanks a lot. Bye.
Bye.
Bye, Roseanne. Thank you so much.
A pleasure. Thank you.